મારી આવશે ધીરે
ધીરે ધીરે આવશે. એમને ઓપરેટિવ મેનેજમેન્ટ કરવાનું નહીં એટલે
કઈ આપણે ઇન્ટ્રોડક્શન બતાવશું મેઇન પાર્ટમાં આવશે ત્યાં સુધી બધા આવશે. So today we will discuss about perioperative management of antiplatelets and anticoagulants, when to stop, why to stop, how to stop, and what to do next. So of the 3 million patients who undergo PCI every year worldwide, approximately 7 to 17% requires non-cardiac surgery within a year of standing implantation. So these are the patients who are in risk group, which require surgery within 1 year of standing implantation. So perioperative management of antiplatelets, and now with introduction of dual pathway inhibition, that is antiplatelet with anticoagulation, it is most important to determine when to stop it, and it requires complex interplay of various clinical parameters and requires individualized approach majority of times. And it is also important to know when to restart and how to restart in post-operative period. So first of all, should we stop antiplatelets or OSE? That depends on risk-benefit ratio. What is risk? Thrombotic or embolic risk? Like in case of antiplatelet, it's a risk of thrombosis, like stent thrombosis. And in case of OSEs, it's a risk of cardioembolic stroke and cardioembolic related complications. So that is determined by disease-specific factors, patient-specific factors, surgery-specific factors, and hypercoagulability associated with any surgery. The benefit ratio is bleeding risk. If bleeding risk is more, it is better to stop all the kind of drugs. If bleeding risk is less, we can continue surgery with ongoing drugs also. So that again depends on patient factor, anticoagulant therapy, and what was the surgery or procedure is to be done. So in short, we will go about drugs. These are various antiplatelets. First and very well known old drugs is COX inhibitor, that is aspirin. Then P2Y12 inhibitors. Out of the irreversible inhibitors are clopidogrel, prasugrel, anticlopidin, and reversible P2Y12 inhibitors are ticagrelor, and now intravenous cangrelor is also available. We are not going into detail of this part because these are short-acting drugs. All CP2B3 inhibitors are short-acting. Dipyridinol cilostatin is not being used much nowadays, but yes, they are also oral agents, which is particularly nowadays it is used in peripheral artery disease. And anticoagulants, again, vitamin K antagonist is warfarin, which acts on factor 9, factor 10, factor 2, and factor 7. Then there are direct inhibitors, that is direct factor 10 inhibitors like rivaroxaban, apixaban, which is also going to be out of this period in this month. So many companies will come up with apixaban in this month. Dabigatran, again it is out of the patent, so it is available freely in market. So these are about antiplatelets and anticoagulants. What we are more interested in this pharmacokinetics of drugs. Out of this parameter, particularly we are interested in this plasma half-life and time since after the last dose for the effect. So plasma half-life for aspirin is only 15 to 30 minutes. Anyway, it depends on the dose. If it is 150 milligram, half-life is more. 325 milligram half-life is again more. But time from last dose to offset is 7 to 10 days. So if at all we need to stop aspirin for any purpose, at least we require 7 days. Clopidogrel, again half-life is 8 hours. Time to offset of action is 7 to 10 days. Prasugrel 7 hours, 7 to 10 days. Ticagrelor 7 hours and 5 days. So ticagrelor we can stop before 5 days or even less than that, before 3 days also sometimes. Cangrelor, it is IV short-acting drug which can be stopped before 60 minutes of surgery. Apixaban, aptifumetin, and tirofiban is basically used for bridging therapy. When we are stopping these agents, we can use this intravenous CP2B3 inhibitors to bridge the therapy. Now aspirin, it is irreversible inhibitor of COX-1 and at higher dose it inhibits COX-2 enzymes also. The irreversibility effect of aspirin causes inhibition of platelet for its lifetime, and that's why action will last for 7 to 10 days after even offset of the drug. And after discontinuation of aspirin intake, platelet function is expected to increase by 10 to 15% per day as a result of new platelet formation on daily basis. Clopidogrel is phenopyridine, it's a prodrug. 85% is hydrolyzed to inactive metabolite state and 15% will get to active metabolite The pharmacological effect again same as aspirin lasts for the lifespan of the platelets. So that's why it also requires to be stopped around 5 to 7 days before the surgery. And there are multiple problems again with clopidogrel like genetic polymorphism and altered intracellular signaling that we are not going into detail of that part. Prasugrel, again it's a prodrug, oral, biodiversity to 12 inhibitor, third generation phenopyridine. Its effect lasts for the lifespan of the antiplatelets. More reliable conversion to active form and more rapid onset of action than clopidogrel, and even longer lasting action as compared to clopidogrel. Ticagrelor reversible. 24 hours after last intake of ticagrelor, antiplatelet effect of ticagrelor declines by 50%. So in case of emergency surgery, yes, we can go with 50% antiplatelet effect after running, and 20% of activity remains after 3 days. So safely we can stop 3 days before the surgery. About anticoagulants.
Before that, see because we encounter a lot of not stand patient. Many patient, non-cardiac patient who are not aspiring clopidogrel, maybe post-stroke or peripheral disease. My point is that one patient whose platelet count is 50,000. Another patient whose platelet count is 5 lakh, 6 lakh. Sometimes iron deficient, chronic iron deficiency anemia and thrombocytosis. And that platelet count is 5 lakh, 6 lakh. So how do you see this patient if you have this antiplatelet agent?
Anyway, low platelet count needs further evaluation.
I am not talking about evaluation. I am regarding the way you said, like inhibition, you need to stop for 7 days. But suppose one patient platelet count 50,000, another platelet count 5 lakh, 6 lakh, 7 lakh.
In 50,000 we need to be more cautious because their platelet generation is definitely less.
My point is aspirin causes the clopidogrel is sometimes 30%, 40% resistance or like mutation is there, and the platelet activation doesn't stop by clopidogrel. What about aspiration? Do aspirin stops platelet function of all the platelets?
All the platelets, yes. At least for whatever is available in body, 7 to 10, whatever we need is 5 lakhs or we need is 50,000.
So in other words, Sir's question.
But it is again on dose dependent. It is dose.
Now, suppose Sir is asking clearly the weight of platelet count is 6 lakh, patient is on 75 milligram aspirin. Would you still stop for procedure? You will not stop for the procedure.
Anyway, we are going to continue aspirin throughout until and unless it is very high risk surgery, like neurosurgery or some epidural analgesia. But anyway, if we need to stop it for a suppose patient with thrombocytosis, 6 lakhs platelet, we don't stop it. We aspirin. Clopidogrel, again, if it is high risk, like post-MI, post-stent with risk level of platelets, I would like to continue.
So is there any comment on guidelines regarding
absolute number of
platelets?
any concern regarding low platelet levels?
I think in metallurgy there is a guideline where they actually say that 30 to 40% of platelets are still available in spite antiplatelet. If your platelet count is on higher side.
Yes, yes. That is there, but when to stop, when not to stop, guidelines does not say anything.
By and large, most of the time is the hip replacement, knee replacement is most of the time is the planned surgery. Hip replacement is sometimes they go immediately.
Could be a time difference.
They most of the time orthopedic surgeons nowadays most of the orthopedic surgeons are restless. They don't want to skip the patient and they want to operate. What I see, if somebody's count is more than 3 lakh, I consider at least 1 lakh platelets are available. 1 lakh platelets you go for surgery. Because 1/3 to 1/4 platelets are not doesn't get inhibited by antiplatelets, so you go for surgery. But if that patient platelet count 1 lakh, I consider only 30,000 platelets, so this bleeding is there.
They can go for surgery.
So this is what I, practically I do.
And even if suppose we say it is not available, but next day it will generate. So next day 1 lakh will generate more, and that are not inhibited. So yes, with
Because if the only way normal. It should not be affected by either drug inhibition or viral infection.
Yes.
If the bone marrow is normal, your platelets are going to be generated and platelet-related bleeding is less likely.
Yes.
Less likely. That's why I wanted to discuss this.
And that's why guidelines is continuously throughout. At least 75 milligram. Okay. So then anticoagulants. Warfarin, that is a vitamin K antagonist. Half-life here is 20 to 60 hours and duration of action from the last dose remains up to 96 hours. Compared to this oral agents, now here we have to consider renal function, but forget renal function as of now. If renal functions are normal, dabigatran effect will last up to 48 hours after last dose versus Epic-7 and Ruparelia where effect will last for 24 hours after the last dose. Renal dysfunction will discuss.
Regarding warfarin, if you go by the half-life of warfarin or will you go by proton midnight?
No, we go by proton midnight.
You will go by INR, not the half-life.
Not half. Not half. Because it is dose dependent eventually. So we will go by INR definitely.
Not only dose dependent, warfarin dose varies from person to person.
That is plasma protein.
Person to person. You cannot go by the dose of the warfarin. It is always the prosamine and is guiding.
Yes. While here there are no tests available. Dabigatran, Ruparelia. Nowadays drop level, you can check drop level, but that is not available in India. That's all. Fortunately, antidotes are available, but again it is very difficult to find. So dabigatran, it's a direct thrombin inhibitor. It's again a prodrug, which is converted to active form by non-specific asparase in liver and plasma. It inhibits fibrin-bound thrombin as well as free thrombin both and irreversible. Epic-7 again direct selective factor 10 inhibitor. Ruparelia we are not going into detail of this. We are coming to the main part, that is antiplatelets in perioperative area and then antithrombotics in perioperative area. So first is antiplatelet in perioperative area. The risk of discontinuation of antiplatelet is the risk of myocardial infarction, stent thrombosis and mortality eventually. So individualized approach is must. We cannot generalize the things. All guidelines cannot be generalized. So individual approach depends on patient characteristic, where we need to determine whether this patient is at high bleeding risk or whether this patient is at high thrombotic risk or both. So high bleeding risk parameters which include female gender, advanced age more than 75, impaired renal functions, anemia, low body weight and history of PI or stroke. These are a part of high bleeding risk parameters.
There are some age criteria. What is that?
That will come in OSC. Even here also we can apply that, but that will come in oral anticoagulants as such. Has blood and charge vascular. Then types of surgery: low bleeding risk versus high bleeding risk surgery. And what are the cardiovascular risks? Like why these patients are on antiplatelet? Was there any angioplasty done? Was there CABG done? If at all it was angioplasty or CABG done, when it was done and why it was done? It was done for ACS or it was done for just liver angina. So that also determines the risk. So these are the thrombotic risks. Who are at low risk? We need to remember only this low risk and high risk category. So low risk category is 4 weeks after only balloon angioplasty. That is 4 weeks after COBA. Nowadays COBA is not done. COBA is done for particular reason when patient needs urgent surgery, he develops myocardial infarction, COBA is done. But even after introduction of newer generation DES, COBA is again out. New generation DES can be implanted even if patient requires emergency surgery. Then second group which is safe is after 6 months of bare metal stent implantation. DES in general, drug-eluting stents after 12 months of drug-eluting stent implantation, they are in low risk versus high risk group. Less than 2 weeks after COBA, that is high risk. Less than 1 month after BMS is high risk. Less than 6 months after DES is high risk. Then there are new subsets. Less than 12 months after complex PCI. What is complex PCI? Complex PCI is PCI where required 3 or more stents. 3 vessels are treated either by CABG or either by PCI. bifurcation angioplasty with 2 stents, left main angioplasty, and total stent length more than 60 mm. So that are in under complex PCI. So after complex PCI, at least planned surgery should be avoided up to at least 12 months. And PCI for myocardial infarction less than 6 months is high risk group. Previous stent thrombosis, again it's a high risk group, because once stent thrombosis already occurred, means their patient are always in high risk category. So these are high risk category. Less than 2 weeks after COVA, less than 1 month after PKMS, less than 6 months after TS, or less than 12 months after complex PCI. Rest everything is in between. So what cannot be determined is intermediate risk. And surgical, which surgery are at minor bleeding risk, which are at low bleeding risk, and which are at high bleeding risk. So balloon, only balloon. So surgery with minor bleeding risk are cataract, glaucoma. Now many times patients come to us for cataract surgery, preoperative antiplatelet. We don't need to stop anything. Cataract is again minor bleeding risk. Even warfarin does not need to be stopped. Still many ophthalmologists suggest that we should stop it. So at least stop P2 vital inhibitor, go ahead with aspirin. So cataract and glaucoma are minor bleeding risk surgery. Dental procedure, this is also very common.
But for dentals and ophthalmology is a major grade, but
So major grade.
even if you ask them to not to stop, they will stop.
They will stop. But at least we should advise to continue aspirin. So for dental, even extraction up to 1 to 3 teeth, these are for all guidelines. These are for dental guidelines, all combined. This table is actually from ESC guidelines 2022. Then periodontal surgery, implant positioning, root canal, subgingival scaling or cleaning are again in low risk group. Endoscopy with biopsy or resection again in minor risk group. And specific surgery like abscess incision, small skin lesions are in minor surgical risk. Abdominal surgery like cholecystectomy, hernia, colon will come in intermediate risk. Breast surgery, complex dental procedure will require multiple tooth extraction. Endoscopy with simple biopsy, gastroscopy or colonoscopy with simple biopsy. Large bore needle puncture like bone marrow aspiration, lymph node biopsy. Non-cataract ophthalmic surgeries and non-glaucoma ophthalmic surgeries are in intermediate risk. Small orthopedic surgeries of foot, hand, arthroscopy are in intermediate risk. Rest everything is in high risk. And there is one more category again very high risk that requires neurosurgical intervention and spinal intervention. That is there here actually, neurosurgery, intracranial, spinal. But that will come in an exceptional group where even a small amount of bleeding also can lead to a major catastrophic event. So what is ECCHA guideline says 2017? So based on this, patients can be divided into 6 subgroups. Low thrombotic risk, low hemorrhagic risk, intermediate thrombotic risk, low hemorrhagic risk, high thrombotic risk and low hemorrhagic risk, and vice versa. So let's see what happens with low thrombotic risk. Forget hemorrhagic risk. Patients who are at low thrombotic risk, we can continue aspirin in perioperative period. We should continue aspirin in perioperative period. P2 vital inhibitors discontinue. Restart within 24 to 72 hours of surgery with loading. And
Loading dose of aspirin.
Sorry.
Loading dose of aspirin.
No, that's what I'm coming into.
Discontinue.
Discontinue when to discontinue. In case of prasugrel, general concession say to stop it 7 days before surgery. Clopidogrel 5 days before surgery. Ticagrelor, there is no general consensus as such, but 3 to 5 days. European guidelines says 3 days, American guidelines says 5 days. Prasugrel, both guidelines are very clear, 7 days. And post-operative, it is recommended that to start with clopidogrel, not prasugrel, not ticagrelor. Start with clopidogrel. Loading dose of 300 milligram, 24 to 72 hours after surgery. Generally 24 hours after surgery. If at all hemostasis is not achieved, then up to 70. For intermediate risk group, it remains same. Continue aspirin discontinue P2Y12 inhibitors within 24 to 72 hours after surgery, start with a loading dose. Here only change is if surgery can be postponed, then we need to defer surgery. How long we should defer surgery, that we'll see next. High risk. Here postponing in high risk of thrombosis, but low risk of hemorrhage. Postpone elective surgery, risk remains same, but continue P12 inhibitors also, because patient is at high risk of thrombosis. And here risk benefit ratio is not favorable in favor of stopping the antiplatelet inhibitors. Intermediate, high thrombotic risk, intermediate bleeding risk, same, but consider bridging therapy. When we are stopping P2Y12 inhibitors and thrombotic risk is high, consider bridging therapy. Both this.
Now that bridging, that should start with protective, you are coming.
Bridging is a detailed again one more slide. So based on this slide, there are two questions. How long we can defer surgery and what to consider for bridging and how to do bridging. So how long we can postpone surgery? How long we should postpone surgery? So after elective, after 6 months of elective PCI and after 12 months of ACS, we should postpone elective surgeries. 6 months after elective PCI and 12 months after ACS. Non-cardiac surgery, which is not time dependent, and which is absolutely elective. Up to 6 months, up to 12 months. Time sensitive non-cardiac surgeries, like sometimes patient is avascular necrosis and it requires some intervention within 2-3 months. Yes, then after elective PCI, minimum 1 month of delay should be advised. Particular some cancer which are in stage 1, which are curable by surgery, that are time sensitive non-cardiac surgeries. So there at least 1 month of gap should be advised after elective PCI, particularly after newer generation disease, not with the older generation disease. And in high risk patient, a time dependent surgery should be avoided at least up to 3 months. So for elective surgeries, which is not time sensitive, 6 months after PCI, 12 months after ACS. For time sensitive NCS, time sensitive non-cardiac surgeries, 1 month after PCI and 3 months after ACS. This should be the postponing period of surgery. Then exceptions. When to stop aspirin? All patients we cannot continue aspirin. So the recommendation is intracranial surgeries, spinal neurosurgery or vitreoretinal eye surgery. There we can stop aspirin for 7 days pre-operative. Not other cases.
Regardless of platelet count.
Regardless of it. Yes. Because what happens in spinal surgery, even a small drop of blood in epidural space, it will hamper your spinal functions. Same with vitreoretinal surgeries. About bridging. Previously there was only one option, now there are 2 options. Stop prasugrel before 7 days, stop clopidogrel ticagrelor before 5 days, continue aspirin throughout, and 3 days prior to surgery, start with tirofiban or antiplatelet infusion. Do a surgery, stop tirofiban antiplatelet 4 to 6 hours before surgery. After 4 to 6 hours of surgery, again start with tirofiban or antiplatelet and loading dose after 12 to 72 hours. So one option is this, either tirofiban or aptifiban. To start
These are all continuous.
continuously, intravenous GP2B3 inhibitors, that continuously. So patient needs to get admitted 3 days before surgery, infusion for 3 days, and then later on continue clopidogrel.
આમાં કઈ એક્સેપ્શન કરું ધારો કે હિપ સર્જરી કરે તો એ લોકો કન્ટિન્યુઅસ ડ્રેઇન મૂકી રાખે છે તો એવા સંજોગોની અંદર ડ્રેઇન કાઢ્યા પછી જ સર્વ કરવું જોઈએ.
No, we can start with this infusion, clopidogrel, and we can discontinue up to 72 hours in this case. But yes, low dose tirofiban or aptifiban can be started. But unfortunately, we do not have any parameter to check its effect also. Like we give tirofiban, we do not have any INR, PPINR or EPD to check the recur. So in that case, heparin would be a safer option where we have some parameter to check. And heparin is again short acting. Even these are also short acting. This half-life is nearly 2 to 3 hours. So after stopping it within 6 hours, it will be fine. Another option nowadays is cangrelor. Now, when to start cangrelor before surgery, it's again a debate. In general, it should be started before 3 days, but in very high risk group, like patient has previous MI, stents, it can be started 7 days in advance. And stop it before 1 hour of surgery or at max 6 hours before surgery. Because half-life is only 1 hour, you can go on with surgery. After 3 to 4 hours of surgery, again restart with cangrelor and then later on loading dose of clopidogrel. So these are 2 options. GP2E3 inhibitors or intravenous antiplatelet.
So suppose on the IV infusion, if bleeding occurs, what is to be done apart from stopping it?
Yeah.
Anything else?
Yes. Then. So unfortunately there are no antagonists. You have to manage with general measures. Either you can apply compression dressings, if at all possible. If not possible, tranexamic acid, fibrinogen, factor 13, desmopressin, platelets, factor 7, activated factor 7 and whole blood. These are the options.
So you are already into intermediate or high thrombotic phase where this was needed, and then you
Now bleeding has occurred and so yes. So
You are
whenever
doing this?
possible,
have you done that? IV therapy, are you giving it any non-cardiac surgery perioperative phase? You are
I have given heparin, I have given
heparin not सर्वत्र आपको काम आपे टायरोफिपेन आप क्यों कह रहे हो?
Tyrosine we do give in a post angioplasty.
That's fine.
Not
During
for
perioperative,
research.
suppose a pancreatic surgery comes in Banker heart, who is having stent 3 months back. You will
Not
give-
as of now, not yet. Not yet.
Oh.
These are options, but bridging therapy is again. See, there are multiple trials. One trial which was done, bridge trial, that was done in 2017, which showed that this bridging therapy is non-inferior to stopping drugs. So, bridging therapy is not superior anyway. This is shown in all trials, even Relight trial.
That statement should be written first year.
Even Relight trial, there was a small arm which was sub-study of Relight trial. It also did not show any effect of bridging therapy. But yes, cangrelor, they did show some benefit, but there are small studies. It is not a trial yet. Because cangrelor is just introduced.
So this bridging is in consensus or it is there in guidelines with tyrosine and cangrelor?
It is there in it.
It's in guidelines.
This is from ESC 2022.
It's in guidelines.
It's in there. Even ACCH in 2017, the guideline is blood management in perioperative period. This is also there. Same chart. It's in both the guidelines. But then guidelines, if you read in detail, again you will find out that these are trials which did show it is non-inferior. But
So what
it
is
is non-inferior.
So LOC and COR is 3 or 2 or what? It must not be class 1A.
No. This is a, they have not given class. This is like anywhere. When we are determining this, consider bridging. Bridging is per se, it is not class 1. It is class 2A. In some cases it is class 2B. Like in very high risk group, it is class 2A. Here it is class 2B. So it is not at all in class 1. And there are no chances that it
Utmost
is
level of
class 1.
documentation and consent is needed because your bill may go anywhere.
It will not come into class 1 because majority of trials are non-inferiority trials. All trials, not majority, all trials. There are 4 or 5 trials, but all are non-inferiority trials. Then, anticoagulants. This is not very widely discussed in guidelines, but it also depends on patient characteristic. High grade is doing more or less same, live more than 75 years. Concomitant use of aspirin makes it in high risk group. Diabetes mellitus and low body weight are patient characteristics who are at high risk of bleeding. Type of surgery that we have already discussed, and thrombotic risk that we will discuss now, low, moderate or high risk. So these are patients who are at thrombotic risk. We are interested in low risk and high risk only, rest of the things are in intermediate. Low risk, atrial fibrillation without any risk factor for cardiac embolism. Risk factor for cardiac embolisms are mitral valve disease, spontaneous echo contrast in LA, dilated LA atrial appendage clot. These are the risk factor for cardiac embolism. So any atrial fibrillation with risk factor for cardiac embolism comes under low thrombotic risk. If there is any history of cardiac embolism in past with atrial fibrillation, comes under intermediate risk. Then atrial fibrillation with prosthetic valve, may it be in mitral position or aortic position or tricuspid, any position, it will come under high risk. History of cardiac embolism, high risk. Rheumatic mitral valve disease, high risk. Thromboembolism, venous thromboembolism within 6 months prior or before 6 months or more than 6 months comes under low thrombotic risk. 3 to 6 months, intermediate. Less than 3 months, high risk. Cerebrovascular accidents or TIA, but without any recurrent stroke, single episode of cerebrovascular disease or carotid atherosclerosis, without any stroke or TIA, comes under low risk group. Multiple strokes or TIA without risk factor for cardiac embolism comes under intermediate. And this recurrent arterial or idiopathic venous thrombosis, recurrent arterial thrombosis also comes under high risk. Acquired hypercoagulability state, high risk, like factor V laden mutation, antiphospholipid syndrome. Venous or arterial thromboembolism within preceding 3 months. Acute intracardiac thrombus visualized by echocardiography, very high risk. Prosthetic valves, these are also a matter of debate, but in general, newer type valve in aortic, like bifurcated valve in aortic position, where we don't require INR in higher range, it comes under low risk group. Newer type valve in mitral position, where our target INR is 2.5 to 3.5, that comes under intermediate risk. Older valves in aortic position, like ball and cage valve in aortic position, intermediate risk group. And 2 prosthetic valves or single leaflet aortic valve, older type valves in mitral position, recently placed mechanical valve less than 3 months, comes under high risk. So in high thrombotic risk group, we should continue with OSCs. Low risk group with low risk surgeries, we can continue with OSC in perioperative period. So let's see. If there is no high risk bleeding, no high bleeding risk, warfarin or vitamin K antagonist continue with INR within lower range. So yes, what sir said, INR is must. Warfarin depends on INR, and we should continue INR warfarin in lower range of INR, like in mitral valve positions. We can continue with INR of 2, but there should not be high bleeding risk as such. Breathing is not recommended. Class 1 is not recommended. NOACs short interruption is recommended. That I'll come to that how short it is recommended. Suppose there is high bleeding risk, but there is no high thrombotic risk. We can safely interrupt oral anticoagulants. Whatever problem is there in between, when there is high bleeding risk and high thrombotic risk, both. If there is mechanical heart valve in patients on oral anticoagulants like warfarin or acetylcholine, bridging here is recommended, that is class 2. Suppose there is any other parameter where high thrombotic risk is there, like coronary thrombosis is there, stent thrombosis was there in past, recurrent pulmonary embolisms, recurrent DPT, and if we can defer surgery in this case, if possible defer surgery up to at least a year of previous event. If we cannot defer surgery, bridging is recommended, class 2. Then in patient with normal renal function, warfarin we all know we should stop, if at all required, we should stop at least 5 days in prior, check for INR day before surgery, and then go ahead with surgery. For NOACs, when to stop it? That depends absolutely on renal function. For patient with normal renal function, dabigatran should be skipped evening dose prior to surgery, on the prior day of surgery. This is for low bleeding and minor bleeding risk. For high bleeding risk, it should be stopped 2-3 days in advance. For renal dysfunction, dabigatran. For normal renal function, at least a day prior. For mild impairment, that is GFR between 50 to 80, 1.5 day prior. For moderate dysfunction, 2 days prior. In severe renal dysfunction, anyway, not indicated. And for high bleeding risk, the timeline will double 24-48, 36-17, 48-96. So for low bleeding risk in general, low bleeding risk may be renal dysfunction, may not be renal dysfunction. Stop dabigatran 2 days in advance. For high bleeding risk, stop dabigatran 3 days. This does not have much effect on apixaban, rivaroxaban, edoxaban, where we need to stop it before 1 day and before 2 days for low bleeding risk and high bleeding risk.
Regarding this 10 inhibitors, the thrombin is indicated here.
No, guidance does not say.
Because ultimately they inhibit thrombin and thrombin is available.
Available.
So they recommend thrombin
Not recommended, but because this is the dependent half time, it is not recommended. Warfarin, PPN are 100%. And for minor bleeding risk surgery like scheme procedure, dental, ophthalmic procedure, we can continue with NOAX but do surgery at the time of next dose of NOAX, like in case of dabigatran, 12 hours after last dose of dabigatran, and like in case of rivaroxaban and apixaban, 24 hours after last dose of rivaroxaban and apixaban. Edoxaban is not available, so we are not talking about that. What about immediate surgery? It cannot be deferred. Immediate surgery which requires surgery within minutes. Here we need to check everything. PT, FPDT, factor 10, thrombin time, everything needs to be checked because if at all everything is delayed, we need to do reversal agents, which is unfortunately in Gujarat it is not available as well. So reversal of NOAX depends on surgical bleeding risk and availability of the agent, and post-operatively recheck coagulation panels and then decide when to restart. For surgery which requires within hours, if possible, delay surgery for at least 12 hours after the last dose of NOAX. Time-sensitive surgery which requires surgery within days, go ahead as routine. Stop dabigatran, stop rivaroxaban as recommended, and then go ahead with surgery. Only problem is this, immediate surgeries, where bleeding risk is very high, even thrombotic risk is very high. There we need to check all coagulation things. But unfortunately, even we say that thrombin time is prolonged, we do not have any agent available to correct it. Unfortunately.
Just documentation that this kind of is available and your bleeding risk is high. That is what they can convey them.
If I talk, we have factor 7 available, activated factor 7. That is available. You can get it, it is from Ahmedabad or something. It is available. This particular NOAX agents, NOAX antidotes.
Plasma here.
We have, not in this, but in Baroda we can get flexible plasma.
Well, if these inhibitors are not available,
Flexible plasma, yes. It is an alternative, yes.
The prothrombin complex concentrate will also.
Yes, that I am coming to that. So, one subset is very important, which is acute venous thromboembolism. If at all surgery is required, when to proceed with surgery? At least 1 month, and preferably 3 months of anticoagulation has to be received after acute thromboembolism.
So monoclonal antibody is available for dabigatran antibody.
Index and alpha that is available, but it's not freely available in market. At least in Gujarat, we don't find.
કોલ કરો તો કેટલી કલાક પછી આપી દે?
Within 4 hours it will get it. But when you require immediate surgery, which is within minutes or hours, cannot. Like Predexa, which was the innovator brand, they have started, if patient is on Predexa, they will give antidote free of cost. But how many patients are as of now on Predexa? After introduction of this generic brands, majority are not on, 90% are not on Predexa.
So that 90% generally antidote will not be there.
But they will have to pay. So, management of bleeding, minor bleeding, general measures like compression, sclerotherapy, blood pressure regulation. For major bleeding, general measures plus correction of acidosis, hypothermia, hypocalcemia, specific reversal agent if available. If not available, prothrombin complex concentrate or antiplatelet, and recombinant factor 7, activated factor 7. So to conclude, all, stop prasugrel 7 days before surgery, stop clopidogrel 5 days before surgery, and even warfarin 5 days before surgery. Ticagrelor or debatable. This is from European guidelines, so they say stop 3 days before surgery. Consider breathing in specific case where there is a high thrombotic risk or high embolic risk. There only consider breathing. It is class 2 recommendation in all guidelines.
This is low molecular weight dependent.
Yeah, in antiplatelets case, it is a IVGP2B3 inhibitor cannula. In case of OSC, it is LMWH or IPL.
Whether one should start immediately withdrawing the warfarin.
Yes. No, after INR comes into lower range. Like whatever is your target INR, if your target INR is 2 to 3, once INR comes into lower range 2, then you start with LMWH or HIPL. And when to restart, again, warfarin needs to be restarted immediately on the day of surgery or maybe just next day of surgery. Because warfarin action will again take 2 to 3 days to come. Then dual direct oral anticoagulant agents in general stop 3 days prior in case of kidney or liver dysfunction, 2 days prior in case of normal kidney renal functions. No breathing is recommended. After surgery, start with, this was about breathing, unfractionated heparin or LMWH, and PK with low dose bleeding risk, we should start immediately post surgery. And for high bleeding risk, start on next day. Warfarin.
And we start with same dose.
Same dose.
Same dose.
But then again, PTI monitoring is.
I think it,
Either lot of NSAIDs and other drug antibiotics are going on, you cannot restart with the same dose. I'll say.
But guidelines is
Guidelines say when the lot of NSAIDs and
that's why PTI
antibiotics
monitoring
and third generation cephalosporin, which are likely to prolong growth of enzyme.
and that's why it is always better to start with this because this does not have many interactions. Like rivaroxaban per se does not have major interaction with antibiotics, anti-tuberculous drugs, nothing.
In case of warfarin,
In case of warfarin,
you cannot
warfarin, if it is the warfarin, there are hundreds of interactions. We don't even know some interactions. And NOACs with low bleeding risk start on next day. After 2 days with high bleeding risk, P2 adrenaline inhibitors within 12 to 72 hours. So this was all about antiplatelets, anticoagulations, when to start. So ultimately, it's individual approach. All patients cannot be fit into guidelines because many times we have patients who have more than 5 stents implanted, less than 1 stent implanted also. So that cannot be generalized.
See, this load is intermediate range high. The patient will say in percentage, right?
Percent.
What is the percentage of stent thrombosis I am going to get?
That we can calculate what you said, Hasbled and Chatwell score. That we can calculate. That is they will give you in percentage.
Okay, thank you.
Okay.
Very good.
I like this picture.
Thank you.
Then